Hello, welcome to another edition of Oral Surgery Journal Club. I hope everyone's having a fantastic day. And today we're going to look at a really interesting article that actually comes from a recent JOMS 2020. It's from Dr. Melville, who's head and neck trained oral surgeon from University of Texas. The article talks about using bioengineered materials, specifically BMP, along with bone marrow aspirate, along with allograft, and using a cocktail of these three ingredients to reconstruct large mandibular defects. Um, it's a retrospective case series where he's presenting how he's used it successfully for the past 5 years. He's got approximately 30 patients who he's treated this with, and he reports quite an impressive 90% success. And he's defining success as the ability to reconstruct the mandible with the following dimensions: 1 centimeter height and 8 millimeters of width, in order that they be adequate for implants to be placed. And he's following these patients and he's showing very impressive pre and post reconstruction images of the pans and the clinical pictures as well. It's quite a long paper, but primarily because of the pictures, and he has a very impressive display of pictures. We'll get through all the pictures. Let's first just talk about his technique and some descriptive statistics. So this is interesting paper. Why? Because the gold standard until some of this newer technology, until this bioengineered approaches came out, would be to use autogenous graft like iliac crest, or for larger defects, vascularized grafts, things like fibula flaps. Whereas these bioengineered materials do not require a donor site, which is key. So patients, either because they're not healthy enough for a donor site, or just who wants to have a separate donor site and a separate morbidity that comes with a separate donor site, increase surgical time and increase complexity, increase complications, etc. For all those reasons, if we could show that this bioengineered material is effective, then now we have a new tool to our arsenal, and that helps us avoid some of the bigger surgeries in the oral surgery world, such as a fibula flap. All right, so he's talking about the advent of this tissue engineered stuff. This is a major achievement. This is all new. And the purpose is to regenerate bone volume without a flap. Now, his recipe includes three things. This is a cocktail, as I like to say, of BMP, BMAC, and allograft. And each one actually serves a slightly different role, and each one is necessary. So we'll just talk about it very briefly. The BMP is the bone morphogenic protein. That is the cell signaling. That's the osteoinductive cell signaling that tells nearby cells to become osteoblasts in order to recreate bone. In addition, you have the BMAC, that's the bone marrow aspirate concentration. And here's a picture of obtaining BMAC from the iliac crest. The BMAC is going to provide the stem cells. So just like the BMP is the signal, it's the osteoinductive signal to tell nearby cells to become osteoblasts, the BMAC, the aspirate cells, are the ones that become osteoblasts. And lastly, the third ingredient in this cocktail is the allograft. And the allograft is only osteoconductive. However, it provides the scaffold. It provides the structural support to prevent the soft tissue collapse. And so these three key ingredients together, all with their nuanced roles, were combined together to reconstruct large defects. Here's a picture showing what the resection looks like. Here's the defect with a reconstruction plate, and then in addition to a reconstruction plate, he added a mesh and some fibrin sealant to help contain all of this graft material in place. Here's another picture of the mandible and then the defect. In this case, instead of using a titanium mesh, he used a resorbable, like a polyglycolic acid membrane, I believe they're made out of. Very impressive newer technology that will break down into just carbon dioxide and water. So that would be a resorbable mesh. And then here you can see the bone material is packed in place. As we go through it, we're going to get to lots of pictures, but first let's just talk a little bit about some of his descriptive statistics. So he had 34 patients in total. 31 of them were continuity defects, meaning these patients had a segmental mandibulectomy or segmental resection where they're leaving the patient in discontinuity. And then 3 of the patients had a non-continuity defect, meaning it was just a marginal mandibulectomy. So they're removing maybe the superior but leaving the inferior plate, leaving the inferior border of the mandible still intact. The patients were on average 40 years old, split between males and females. The defect size on average was 5.6 centimeters, which is significant. So on average it was less than 6 centimeters, but I should say on occasion they were a little bit larger than 6 centimeters. Post-operatively, he put the patients in IMF at least 21 out of the 34 times. So about 2/3 of the cases were in IMF, 1/3 weren't. For about 2 weeks, for about 3 weeks, he put them in IMF, and now approaches. So about half and half, which is interesting. Half went via transoral approach, 15 transoral, and then extraoral, meaning going through the neck, was 19. Now that is significant because when you consider grafting defects of this size, one thing that you're principally going to be concerned with would be salivary contamination. And he was able to show that even when he went transorally, which is about half the time, he was able to achieve similar success. And there was no difference in success when he compared the transoral approach versus the extraoral approach. There were only a few cases of failure, and there was one from each group. So no difference whether he went transoral or extraoral. And lastly, success. So he had 90% success, so 27 out of the 30 cases of success when he looked at the continuity defects. And the non-continuity defects, those were 100% successful, but obviously those are a little bit less impressive. What I really want to point out here is 90% success, which is quite an impressive number. Even when you look at vascularized grafts, of course, you're going to get graft failure, the flap's going to fail, you're going to get flap take back. So 90% success is something to be really impressed by, and that's something that we're now being alerted to, that this is a viable technique, that we can start to consider using bioengineered materials for graft in the appropriate patient population. Okay, so let's just talk briefly about what his protocol was. So all the patients were found to have acute mucosa before closing, and they were told that it had to be aborted if they couldn't close well. All the patients were placed in IMF for 3 weeks, and then very strictly, although seems to be effective, they put all the patients, and they made all the patients NPO for 2 weeks and gave them a feeding tube, which again does seem quite strict and harsh and difficult to tolerate from a patient perspective, but if it led to their success, then certainly worthwhile to consider. They gave all the patients glycopyrrolate along with antibiotics. The glycopyrrolate was to decrease the salivary pooling. Again, another meticulous detail. The closure was done in layers, again to achieve watertight seal. They did vertical mattress plus some interrupteds, plus if there was any questionable margins, they also did dermabond on top of that. Again, all the patients were NPO with a feeding tube for 2 weeks, and here's some of their successes. So here's a defect and a reconstruction. I'm going to go through the pictures relatively quickly, even though these are quite beautiful pictures because they just become one after another very similar. Again, you're going to see large defects, in this case even greater than 6 centimeters, and success with this bioengineered technique. All these patients were treated the same, and all of them have quite impressive results. They were all able, for success, they were all eligible for implants. Some of them financially didn't get it, but they had the adequate bone and if they were interested. Look at that bone, really quite beautiful case. All right, so now a couple things just as we're wrapping up, just to discuss. One thing I don't know if I really mentioned yet, that none of these were all benign path patients. So none of these patients were about to undergo radiation, and that's important. Often when it comes to large mandibular defects, there's 2 categories. There's the benign path, which everyone in this paper was of that category, and then there's patients who have malignant squamous cell carcinoma, and then even after a large segmental resection, they're about to undergo chemo and radiation. And the radiation is ultimately which would be a contraindication to this technique. So that's important just off the bat to point out. And we're not dealing with any squamous cell carcinoma patients. We're not dealing with any radiation patients. All these patients have healthy wound beds. They have good vascularity to maintain this non-vascularized graft, which is made entirely of bioengineered materials, and all of it is not requiring a donor site. So patients in this population were patients had things like ameloblastoma or central giant cell granuloma or ossifying fibroma or even OKCs, but none of these patients had any malignancy of any sort. Second thing to point out, it was a very strict protocol in terms of the NPO and the feeding tube and the IMF, but when it comes to a graft technique like this, it does make sense if you want to try to avoid, you want to achieve a union and avoid the micro movement that can lead to infection. It does seem to be a beneficial technique, and it seems to be very successful. The three key ingredients, each one providing a different role. And again, their pictures speak for themselves. So I'm going to leave it there. I thought this was an interesting paper with an interesting technique worth discussing. Certainly, if you're a head and neck oral surgeon, you have access in your hospital or institution to a microvascular surgeon, and you can offer fibula flaps, then that's obviously going to be one of your mainstays of treatment for large defects. But not every hospital, certainly a smaller hospital, may not have access to such surgeries and techniques. So this is great to know that this, when done well and carefully and meticulously, can lead to successful outcomes. All right, I'll leave you guys there. Just let me interested in hearing your feedback. What are your thoughts? Have you guys tried using bioengineered materials? Have you found it in your hands to be effective? And I'll see you guys next week. Thank you.